Thank you, good afternoon, and thank you, Zoli, for your kind invitation. You gave me an interesting topic because, and this is relevant as well, because do you remember what was the 3 top health threats to prepare against mentioned by the Health Emergency Preparedness and Response Authority of the European Commission in 2022? The first was the pathogens with high pandemic potential, the second, chemical nuclear threats, and the third one is antimicrobial resistance, which will pose one of the greatest risks to human health, and that's where we are in trouble now. We could say that, okay, sepsis mortality seems to be decreasing, but the problem is it only seems to be. Because if we control the studies for the severity at the time of admission, we will see that there is no significant change in mortality. So actually, the reason for the reduced mortality is probably that the patient gets earlier to the hospital. And we have to brace ourselves for the super bugs coming, because you see the timeline here. On the top of it, there are the antibiotics. On the bottom of it, you can see that as soon as there is a new antibiotic discovered and commercialized, the resistant mechanism soon develop. Cephalosporins were quite successful. It took 20 years to get the resistance. But for example, for linezolid, it was less than half a year. And by 2050, the mortality from these antimicrobial resistance is expected to increase by 70% in the patients who characterize our ICU, so the patients above the age of 70, because by this time in Europe, more than 30% of the population will be above the age of 65. So there will be our patients. So we are not getting forward. Probably the question is not good. Let's have a look at from a different aspect. And if we consider who we treat, actually, our whole body is dominated by microbes. They are much more than human cells. And we all together make an ecosystem. So we not only treat human cells, but actually at least 65% microbes as well. Microbes are only 3% of our body weight, but they are really important, and they have a behavior just the same as humans. So if they feel uncomfortable due to a critical illness, due to ischemia reperfusion injury, the pH, the vapor, the temperature, the nutrients changes in the gut, then they will become aggressive. They don't like that, and they want to survive. What will they do? They will activate the virulence genes, and they will destroy the other species. They will combat for the nutrients. For example, Pseudomonas will kill the lactobacillus species very quickly, and they will also activate the virulence genes and the antimicrobial resistance genes. And that's what we see on the picture, that in the green square, that's your gut microbiota from the American Human Gut Project. And that's how it would look like when you get a critical illness. And you can see that at phylum level, the proteobacteria will dominate your gut, Pseudomonas, Klebsiella, Acinetobacter. And if you make the surrounding even more hostile for these bacteria, which are us and living with us, they will be even more aggressive. And a good method to anger them is giving antibiotics. So that's the situation with the red, what will happen at the time of discharge. And if you alter your gut microbiota, then you will lose the protection against the colonization of the pathogens. Because have a look at how many methods the normal commensal bacteria have to protect you against the different invasive proteobacteria or enterobacterales. And at the same time, they have a very important function, because they communicate not just with your muscle, but with your brain, with your other organs, with your kidney. This is just an example that how do the microbe communicate with the brain? They give chemical signals. A majority of the tryptophan synthesis happens in the gut by the microbes. They produce serotonin. That's why you are happy after lunch. And they produce immune signals as well. They are responsible for central nervous system inflammation and give neural signals as well. So, and this is a proven aspect already, because if you just transfer a human feces from mouse, and this human feces is coming from a Parkinson's syndrome patient or a schizophrenia, autism patient, or a patient treated with depression, where the mouse will have the same syndromes. And once dysbiosis happens, that already has a close correlation with your predicted mortality. There is a point of no return until you will, after the point you will die. Actually, if you die due to malnutrition, you don't die due to immunological problems, but you will get colonized with gram-negative bacteria in the trachea, and the sepsis will kill you. So if the bacterial firmicutes ratio is too high or too low, there is a serious problem, and it correlates with the mortality. And the situation is even worse in yellow. You can see in chronic patients where the patient has already a dysbiosis. And once this cirrhotic patient gets, for example, an acute illness, then the mortality will definitely be much worse once the dysbiosis will worsen. And of course, we will anger our gut microbiota, because we will give antibiotics to the patient, for example, beta-lactams or fluoroquinolones, which will have very long-term impacts on the intestinal microbiota after 7 days already, or even 3 days. The antimicrobial resistant species will remain in the gut, and of course all the antimicrobial sensitive species will be destroyed. And the resistant species can transfer their resistant genes through plasmid-mediated method to the other ones, and this effect will remain for usually in ill patients for more than 12 months, and sometimes for 2 years. So if you give clindamycin to healthy volunteers for 7 days, on the 3rd day already you can see that the antimicrobial resistance genes are activating. This is the upper part of the figure. The lower part are the non-exposed subjects. And you can see the Bacteroides species, MDR, multidrug resistant clone types, being represented with gray for 12 months or even more. Sorry for the busy picture, I will explain everything. Depending on the severity of the illness, whether the patient is just treated with a community-acquired infection at the outpatient department, or a hospital-acquired infection in the hospital, or ICU-acquired infection in the ICU, that's how the severity increases. Is there any difference in the gram-positive bacteria presentation? There is no. So actually, who are really who are really in the picture in this situation are the bacteria who can activate the virulence genes, and these are the gram-negatives. The Klebsiella, the coli, the Pseudomonas, and the Acinetobacter. And you can see that the percentage, the representation in the nosocomial infections are growing in parallel with the severity of the disease, and the same thing happens with the multidrug resistance of these species. And you are colonized with MDRs, at least 8% of you, at least. If you go to India, it will be 90% of you already. So it's very frequent on ICU admission that our patients are already colonized, and you can see that this colonization will increase with 1.4% each day spent at the intensive care unit in a critical state. Actually, it's due to the critical illness and, of course, to the antibiotics. And once you are colonized with multidrug-resistant Enterobacterales, they will go into the bloodstream as well, with a very high risk, 3.5. And then the survival probability will drastically decrease compared to the non-colonized patients with green. The colonized patients, the survival is with red. And there is a patient group where this is really serious, the hematological patients. In this patient population, the risk of bloodstream infection with the same pathogen in multidrug-resistant colonized hematological patients is with an odds ratio of 52. It's extremely high. That's what we can see in the everyday practice as well. So if they have ESBL, Klebsiella in the perineal swab, then probably they will have it very soon in the blood culture as well. If you have a dysbiosis, it not just have an imminent effect, but a long-term effect as well. In this study, they checked that 3 patients groups, according to the probability of dysbiosis, What is the frequency that these patients will be readmitted to the hospital due to, for example, infective reasons? The three groups are non-infection-related hospitalization, for example, hypertension patients, probably with normal gut microbiota. Infection-related hospitalization, there will be dysbiosis already. Hospitalization with Clostridium difficile infection, there is a severe dysbiosis in this patient group. If we check that which patient group is readmitted to the hospital within 90 days due to non-septic diagnosis, there is no difference between the three patient groups. But if we check which patient group is readmitted to the hospital within 90 days due to sepsis, then the patient group who had the most severe dysbiosis has the highest chance to be readmitted due to a septic reason. So what can we do? If we have a look at the EPIC-3 study, we have learned from that about 54% of our patients have suspected or proven infection in the intensive care unit, but 70% of the patients get at least one antibiotic. The numbers do not add, and of course, gram-negative dominates the picture, so there is room for improvement here. What can we do? Get the surrounding of the bacteria comfy in the gut. So A, B, C, D, E, restore the homeostasis as soon as possible. Cells can't wait, as Zsolt usually say. Then get to a quick diagnosis and get a good, proper antimicrobial treatment. And what you can see where the red arrow is, how much an infectious disease specialist can help in this. This is the survival difference if you consult with an infectious disease specialist, either microbiologist or infectologist, during the first few hours or not. There is a significant difference whether you can get the right antibiotics. And of course, it's important not just to start, but to stop it. Stop it in time, give the minimum necessary dose, which is necessary to get over the infection. So what are the actual numbers? We are a high-income country, so let's have a look at the third column. We can diagnose the patients. We use microbiological cultures, 95% of us at least. But there are no available clinical microbiologists in 30% of the cases, and no pharmacist in almost half of the cases. This is a room for improvement. We have antibiotics. Everybody has them, fortunately, in this section. But the problem is that we don't monitor them. So, for example, when we give beta-lactam antibiotics, 40% of us do not monitor the level of these antibiotics. This could help. What about direct restitution of the microbiota? That's difficult. That's for the future. We can give microorganism supplementation by next-generation prebiotics, engineered microorganisms, or fecal microbiota transplantation. We can suppress microorganisms. This is research going on to suppress Klebsiella pneumoniae and especially ESBL Klebsiella. With phage therapy, there are promising results. At least in mice, we can already treat it. We have predatory bacteria, which can target certain Enterobacterales, and we can get the inhibition of antibiotic resistance genes with RNA-guided nucleases into the bacterial cells. This is a research going on as well. Let's get a little bit closer to the bench, from the bench to the bed. This possibility, we have possibilities to use probiotics and fecal microbiota transplant nowadays as well. How do they work? What would you say which is more effective to restore dysbiosis? This was a study carried out in healthy volunteers who got 7 days ciprofloxacin and metronidazole. The first group, after reaching a very severe dysbiosis due to these antibiotics, the first group got a fecal microbiota transplant, the second group probiotics, and the third group just had a restitution spontaneously. Actually, what we could see with the brown, that the restitution was the best in the group where fecal microbiota transplant was carried out. And it was the worst in the group who got probiotics. For the moment, probiotics are inhibited to be given in the intensive care unit. It's prohibited to give them. But actually, we can see that they do not work. Just a few species is given to the patient and not the whole ecosystem is restored. So spontaneous restitution is even better than given probiotics. Of course, fecal microbiota transplant, which seems to be the most promising, has its limitations, and we have the FDA warning. We need a very, very severe donor screening and donor stool testing as well, because you can transmit MDR bacteria with it, and you can cause life-threatening sepsis. But this is nevertheless a promising future. To conclude, what we can see nowadays is that there is a change in perspective from an antimicrobial focused to a microbiome focused vision. We take into consideration that we are an ecosystem nowadays. This biosis is the result of not just the critical condition, but of medical interventions and antibiotic treatment as well. It will correlate with multi-drug resistant bloodstream infections, mortality, and even rehospitalization due to sepsis. We can prevent this perturbation if we early restore the homeostasis of the septic patient. The antimicrobial treatment is targeted and timely. For this, we can use the help of infectologists, microbiologists, and pharmacists. And future researchers are focusing on using our own microbes to combat the infections, so just restituting the natural way. And we have to remember that intervening in the microbial ecosystem without proper knowledge can easily be harmful. Thank you very much.